If you walk into any hospital, chances are somebody in there is taking one of these drugs that we're talking about today. So it's important as a future healthcare professional that you know how they work. Hey everybody, Organized Biology here, where we make difficult biology concepts simple. And we've made a video previously about diseases like cardiovascular disease and high blood pressure, but today we're talking about the pharmacology of certain drugs that will treat these conditions. So we're going to go into the details a little bit, so I recommend getting a free diagram for all three of the ones we're going to use today by emailing organizedbiology@gmail.com and put in the title line, drug notes. Again, it has to be drug notes, and then email organizedbiology@gmail.com. Awesome. So we're going to start first with blood pressure medications and then one cardiovascular disease medication, starting with Metoprolol. Always tells you that it is a beta blocker. So what the heck is a beta blocker and how is it going to help improve blood pressure? Well, first we need to know that blood pressure medications, the goal for all of them is to lower blood pressure. Why is that? Well, we know that blood pressure is actually a good thing. When the heart contracts, it's going to pump blood through those arteries of the heart, the pulmonary artery here in the aorta, and it's going to push that blood out and exert a force on the walls of those arteries. That is basically just our blood pressure, right? However, because of the American diet and other things like sedentary lifestyle, etc., we can actually have a narrowing of these arteries. So now the diameter is really small and they're stiff. And so therefore, anytime you squeeze those vessels, it increases that pressure. Imagine if you're like squeezing a tube full of fluid and you push on it, there's going to be pressure pushing out on your hand. So that's going to cause high blood pressure. Therefore, we need to lower the blood pressure because high blood pressure over time can damage arteries, damage cells, cause strokes, all sorts of bad things. So let's improve it. How? Let's start with our beta blockers. First off, you look at the word beta, right? What does that refer to? Well, it refers to the beta receptors that are found in the beating heart. Remember, beta beating heart. So here is a beta receptor right here in the heart, specifically in the heart muscle tissue. Okay, we'll look at that in a second, as well as in the SA node. That's going to set the pace for the heart. So that's a beta receptor in the SA node of the heart. Okay, but it's not just beta receptor, we're going to block the beta receptor, right? So this medication, Metoprolol, I'm going to draw it here in a second as basically just going to jam this receptor so that we can't get anything else to bind to it. Well, that begs the question, what normally binds to it? Well, normally functioning in the body, we will have a commonly occurring molecule that your adrenal glands produce called epinephrine. So I'm going to draw some epinephrine here, and this is constantly circulating in your bloodstream. I'm just going to put epi. And it's especially elevated when you're doing high strenuous activity, but there is a baseline. You always have some in there. And epinephrine will bind to this beta receptor in the heart as well as in the SA node, and it will do a couple of things. Number one, it will increase the contractility, the strength of contractions of the heart. So I'm going to say increase contraction strength. And it's also, if you look at the SA node that keeps the pace for the heart, it's going to increase the heart rate. Okay, so epi increases contraction strength and heart rate. Contraction strength by binding to the heart muscle, heart rate by binding to the SA node. But what's actually happening here and how does blocking it decrease heart rate and decrease contraction strength, therefore decreasing blood pressure? Because if we have less blood basically going out of the heart, the pressure on the vessels will decrease. Well, how does that work? Well, let's look inside the heart muscle here. So I'm going to look at the cardiac myocytes, muscle cells, and we're going to zoom into it. Now we're going to focus on two main sections here on the top for this drug. So here we have our beta receptor. Once again, we see him and we're zooming in on the cell. Beta receptor. And this is actually something called a G protein coupled receptor. You can learn about membrane proteins in this video here. But that membrane protein inside the heart muscle, so here, this is the heart muscle cell. It's got membrane proteins, a lot of them. And that beta receptor, I'm going to show you, will bind epinephrine. So here comes epinephrine, binds to it. Okay, what's going to happen? Well, what will happen is that G protein, anytime something binds in biology, there's going to be some sort of shift or shape change, and that shape change will induce a lot of cascades of actions. It's basically like you're opening up the waterfall, like the dam of the waterfall, and now the water's rushing through. So what do? Well, we attach that epinephrine. Now what's going to happen is it's going to activate that G protein. So we want to write activated G protein. And that activated G protein, usually a GTP if you want the specifics, is going to go to a big enzyme here, very common in a lot of your cells, and it's called adenylyl cyclase. Adenylyl cyclase. Cool sounding name. All I want you to focus on is the ACE. This is an enzyme. It's going to cut some stuff apart. So anytime it just ends in ACE, it's an enzyme going to cut something apart. What's it going to cut apart? Well, interestingly, we're going to take ATP, so that's the energy currency molecule, your heart's always making it, and it's going to cut it up, and it's going to turn it into something called cyclic AMP. You may see this in a lot of pharmacology classes. This is called a secondary messenger. Secondary messenger. You can probably predict why. It's kind of coming after the first messenger, epinephrine, right? Now, secondary messengers are going to increase the response. It's basically like Paul Revere riding through the east side of the United States saying, the British are coming, the British are coming. He's stimulating a lot of people to action. Okay, that's going to be our secondary messenger, otherwise known as cyclic AMP. Now, cyclic AMP does this. Check this out. It is going to go and open calcium channels in something called the sarcoplasmic reticulum. Sarcoplasmic reticulum. Now, what the heck is this? Well, if you watch any of my muscle videos, this is a big storehouse of calcium inside your heart muscle itself. So it's kind of like a little pouch of calcium inside the heart muscle. So it's not gotten out yet, but it's sitting inside of here. Cyclic AMP then is going to open up all of these calcium channels. So it's going to open them up. And therefore, if there's a lot of calcium in the sarcoplasmic reticulum, where do you think all that calcium is going to flow? So I'll draw them just kind of as little dots here. Where do you think all that calcium is going to go? Well, we know things also like to flow from high concentration to low concentration. So there's a lot of calcium in here, it's going to get out. So all of a sudden, all this calcium is flowing out. And what's going to happen? Well, if there's a lot of calcium here, if you know how muscles work, calcium is the key to contraction. Calcium is the key to contraction. So we see down here things called sarcomeres. So all of these repeating units right here are called sarcomeres. Sarcomere is basically the unit of contraction of the heart and also your skeletal muscles. And what will happen is all of these are going to accordion together, all of these lines here, Z lines, they're going to accordion together, thus contracting the heart muscle. How does it do that? How does it know when to contract? Well, you can see on the sarcomeres, there's going to be a little calcium receptor. It's actually called troponin, and the calcium is going to bind to it, and whenever the calcium binds to it, it tells the sarcomere to contract or shorten. Okay, so calcium is the key for contraction. That was a lot, y'all. Now, why am I teaching you all this? Because that was when epinephrine, that we mentioned at the very beginning, binds to it. And that is going to obviously increase the calcium amount, therefore increasing the contraction strength. And that's in the heart muscle. The same thing happens in the SA node. It's just going to increase how fast the heart contracts, right? The heart rate, as we mentioned before. So, if we take metoprolol, however, if we take metoprolol, a beta blocker, we are going to therefore block several of these beta receptors. Therefore, if we block these beta receptors, there's the first blooper of the day, epinephrine won't bind. If epinephrine doesn't bind, guess what? Everything downstream does not happen, and we have less calcium amount. So I just want you to remember that metoprolol is going to decrease the calcium amount in the heart muscles and the SA node, therefore decreasing contraction strength and heart rate, therefore decreasing blood pressure. Isn't that amazing, right? It's so fascinating how complex the heart is naturally working, and then drugs can kind of target them to change their effect. Brilliant. Now, we're going to go back to the heart here in a little bit. We're going to talk about a couple other channels, but let's move on into the next blood pressure medication. That is our ACE inhibitor. All right, ACE inhibitor. Hopefully you guys know your RAS system. We're going to review it a little bit. Now, ACE doesn't just mean like, you know, the thing you get in tennis when you get a serve and the other person doesn't return it, but ACE stands for, I'll write it down here, angiotensin converting enzyme. Angiotensin converting enzyme. Okay, so it's going to convert something dealing with angiotensin. So before we talk about how this works, we need to know what the heck that angiotensin is. Well, let's say we're going at the kidneys, okay? So the kidneys are going to have a major play here. Well, the kidneys are going to need a lot of blood coming into them, right? So the kidneys have a goal. The goal of the kidneys is to filter about 120 milliliters every minute. And that's, again, the filtration rate. That's the filtration rate of the kidneys, otherwise known as GFR. You may hear this or see this on a medical chart. It's glomerular filtration rate. Basically saying, hey, when the blood gets to the kidneys from the renal artery, I can write that here. When we get there from the renal artery, how much are we filtering, right, into the nephron, which is the functional unit of the kidney. So again, this is the nephron, and we're saying how much are we filtering from the blood plasma into that nephron. That should equal approximately 120 milliliters every minute. Okay, so that's very, very important. We need to keep that constant. So we know that that's a homeostatic variable. However, what if hypothetically we were to lose some blood, or we're really dehydrated, losing some fluid, and now this decreases to say 80 milliliters a minute? Okay, so we decrease our filtration rate due to some reason down to 80. Is homeostasis achieved? No. So we need to bump this back up. How do we do it? How do we do it? Well, we know that the kidneys are going to release something called renin. Okay, so the kidneys, in response, will release a hormone called renin. Okay. What does renin do? Well, renin first goes into the bloodstream. We know it's a hormone. So here we've got renin in the bloodstream. Let's just draw it as like a circle here. Now, trust me, we're going to get to ACE here in a second, but renin is going to act, as I said, a hormone. It's going to go in the bloodstream and go everywhere, but renin is actually something called an enzyme. So renin is an enzyme that's going to clip off something. It's going to clip off something. Well, what the heck is going to clip off? Well, we know normally functioning, your body will have a liver. That's a really important thing. So hopefully you have your liver. And the liver is going to constantly be throwing stuff into the bloodstream. Now, it's not going to be through the renal vein. I know that, but this is just a diagram. It's going to be tossing in something called angiotensinogen. Angiotensinogen. Okay, we're getting to that thing, right? But we need to know what this is first. A couple things with the liver first. The liver always makes ogen things. That basically means it is an inactive thing. Inactive molecule. It's not really doing anything at all. And so angiotensinogen, we'll just draw it as, I don't know, like this. Big old triangle. Okay, is always in the bloodstream. Always present. Always present. But then enzyme comes along, right? And it is going to come and clip angiotensinogen. Okay, so renin, right here, is going to come and clip angiotensinogen. What does that turn it into? Well, it's going to turn it into angiotensin 1. So I'm going to draw angiotensin 1 maybe as a my son is talking in the background if you can't hear it. So it's going to convert it into something called angiotensin 1. He's having fun. Trust me, he's not crying. Okay, so now we've got angiotensin 1 that also does nothing. Kind of interesting. So the first two things don't do anything. So we're not even going to worry about them. Angiotensin 1, though, is going to get into circulation, and it's going to come over to the lungs, interestingly enough. So here's angiotensin 1, AT1, and it's getting into the lungs, where we have, our angiotensin converting enzyme. Okay, so here is our, again, ACE, our angiotensin converting enzyme. Well, what do you think it's going to do? Well, it's obviously going to convert angiotensin 1 into angiotensin 2, AT2, right here. So I'm going to write that in here, angiotensin 2. And I always remember that angiotensin 2 is the dude, okay? It's going to do a lot of things for the body. So what's angiotensin 2 going to do? Well, it's going to come and bind to receptors on the inside part, the endothelial side part of blood vessels, specifically muscular arterioles and arteries, and it's going to bind to them. Well, what happens now? Well, when AT2 binds here, we're going to cause something called vasoconstriction. Vasoconstriction. We know that is going to obviously take those arteries, and instead of them being nice and wide like that, they are now going to be pretty narrowed up. Okay, so why are we doing that in the first place? Well, think about it. What started the whole process? Well, we know it was the filtration rate, and it dropped, right? So the kidneys are now inadvertently, well, kind of indirectly making a molecule that's going to narrow blood vessels. What does that do to blood pressure? Well, obviously, that is going to increase our blood pressure, but in the process, it's going to increase the blood pressure at the kidneys, right? So if we increase the blood pressure at the kidneys, what's going to happen to our filtration rate? Well, it is going to bring it back up to that 120. Yeah? Isn't that fascinating? So by increasing the blood pressure via that angiotensin route, we're going to get that filtration rate back up to normal. So the kidneys love that. But here we are. We're taking a drug called an ACE inhibitor. We're going to inhibit this process, because if we inhibit the process, we won't raise blood pressure, but we will decrease blood pressure. Okay, so how do we do that? Pretty simple, y'all. Where's the ACE? ACE is at the lungs. So the ACE inhibitor is going to come in and bind to angiotensin converting enzymes on the lung. So here we have our medication binding to those. So therefore, what specific part of this process does it block? It blocks AT1 going to AT2. And remember, AT1, what does it do? Nothing. It is just as inactive as angiotensinogen was, okay? So by taking an ACE inhibitor, Lisinopril is a common name of it, it's going to inhibit that process, therefore decreasing blood pressure. Now, last one, we have a loop diuretic. This is going to be a blood pressure medication, and we're looking at something that deals with a loop, not a roller coaster, but it kind of looks like it, and it's going to be a diuretic. Whenever you see diuretic, it means to pee or urinate. Okay, so anytime we're talking about pee, we're talking about the kidneys. All right, so let's look inside the kidneys here. Well, first we have the nephron, as I mentioned, the functional unit of the kidney. You've got about 1 million per kidney. And at the nephron, we again are filtering blood plasma into what we call the tubule of the nephron. So I want you to know that inside this green section is all the tubule. Now, to make matters easy for you, think if it stays in the tubule, it's going to get peed out. So if something stays in the tubule, it's going to get peed out. Stays in tubule, it will get peed out. Okay? Because eventually it will lead, as you can see here, to the kidneys, to the ureters, right? All the way out to the bladder and out through the urethra. So let's just say there's stuff in here, okay? There is stuff in here that we filtered out. It could be water, it could be salts, it could be hydrogen ions, whatever. If it stays in that tubule the whole way, it's going to get excreted out as urine eventually. Okay, so think about it already. We're going to make a diuretic. Okay, we're going to make you pee more. Why are we doing that? Well, we know if we pee out more, we have less blood volume. So if we decrease blood volume, I'm going to say blood V, if we have less blood in general, what will that do to your blood pressure? Well, right, decreases. Just like if you have less fluid in a water balloon, there's less pressure inside of the water balloon, right? Okay, so how does this work? Well, we know we need to have the stuff in the tubule get out more. We need to make you pee out stuff, right? So how do we do that? Well, we know that inside of the kidney, specifically in this loop here, you see this loop going down and up. This is called the loop of Henle. Okay, loop of Henle. Henle's probably a dude who, figured the sucker out. And in the loop of Henle, we have these really cool proteins on this side, the apical side of the tubular cell. So you see how I kind of blew up these big green tubular cells? And we've got membrane proteins here, common theme, a lot of membrane proteins. And these are called sodium, chlorine, potassium cotransporters. Cotransporters. Big long name, right? Well, what do we mean by that? Well, we know that we will have sodium ions in the tubule that we got from the plasma of the blood. We will have potassium ions, same place, and chlorine ions, right? So basically salts and potassium. Well, if you think about it, these are actually electrolytes. These are things that your body naturally wants to bring back into your bloodstream because they're healthy for you. It's the reason you actually drink Gatorade. You're trying to get electrolytes back into your bloodstream, correct? So the kidneys want to be good at bringing them back in the blood, reabsorbing them. So the co-transporters, where moving multiple things, will bring these things out of the tubule and back into the bloodstream. So now we'll have that sodium, potassium, and chlorine all back into the blood, all happy. But the problem with that, once again, for our patient here, is if we have more electrolytes in the blood, water likes to follow it. So water is also going to accumulate in the blood, and we are going to have a very high blood volume, therefore a high blood pressure. Therefore a high blood pressure, right? High blood volume, high blood pressure. So instead, we're going to take something called a loop diuretic. Furosemide is a common one, and that loop diuretic is actually going to jam itself into these cotransporters. It's going to come in here and jam and lock itself in to these cotransporters. So here comes furosemide, right? Loop diuretic. If we block those cotransporters, now we can't get the sodium, potassium, and chlorine back into the bloodstream. Therefore, we can't get the water back into the bloodstream. And therefore, that water, sodium, potassium, and chlorine will all end up where? Well, obviously, it's going to end up as urine. It's going to get peed out. That's what a diuretic does. It makes you pee a lot, but it decreases your blood volume, therefore decreasing blood pressure, okay? Now, one note on this you will learn in your nursing school is this furosemide is actually called a potassium. I'm going to bring it down here. This is called a potassium wasting diuretic. Potassium wasting diuretic. Because we are losing potassium in the process, okay? So sometimes if we have a person with low potassium in the blood, hypokalemia, we can actually give them a different medication. They end in actone usually, like spironolactone, and that is actually a potassium sparing diuretic. Action on a different channel, keeps potassium coming back into the bloodstream to prevent hypokalemia. Very cool. So that is, again, how all these blood pressure medications work. If you want to learn more about other blood pressure medications, you can actually watch this video here. I talk a little more in detail and about a couple more because these aren't all the classes, but they're the most common. Okay, last one for this little section. We're going to talk about a cardiac glycoside, okay? Basically just acting on some sort of glycosylated chain, and it's going to be called digoxin, okay? What are we doing with digoxin? Well, let's come back to the heart. Digoxin is going to treat two main diseases, okay? So I'm going to come over here. It's going to treat two main diseases. It's going to be heart failure, and the other one is going to be arrhythmias, usually AFib. So usually AFib is a common one. That means atrial fibrillation, where these atria, the top two chambers of the heart, are literally fibrillating, shaking, and they can't efficiently pump blood through into the ventricles, and that can actually lead, interestingly enough, to heart failure, okay? What's heart failure? We talked about in the previous video about diseases, but it's basically when the heart is filling with blood and needs to get the blood out. Get the blood out. It's basically like your boat is sinking and there's fluid coming onto your boat and you have to pan the fluid off of the boat so you don't sink. Well, in the heart's case, during heart failure, it can't get the blood out efficiently enough. So the heart needs to essentially get stronger in order to get the blood out properly. How do we do that? Well, think about it. what is the key to helping the heart contract? What is the key to helping the heart contract? We know it was calcium, right? Calcium's the key to contraction. So think in your mind, we want to basically increase the amount of calcium at the heart, right? Because if we increase the amount of calcium, then we're going to have a stronger contraction. So let's see how digoxin does that to help increase the heart strength to decrease the chance for heart failure. Well, we have normally functioning in the heart, we've got a sodium potassium ATPase pump. That's a lot of words, right? Well, we know it's dealing with those ions, sodium, potassium, electrolytes. ATPase basically means it needs to have an investment of ATP energy. I drew ATP in blue earlier, so I'm going to do that again. So ATP is a cellular currency of energy. It is going to get clipped off, turn into ADP and a phosphate. That just basically means we're using the energy of the ATP. And it is going to throw sodium, potassium different places. Number one, it's going to throw sodium out. Number two, it's going to throw potassium in. Okay, so we got potassium coming in, sodium flowing out. Okay, well, this is kind of an interesting process. If you want to learn why this is happening, you can learn about graded potentials, action potentials here. Talked about why we do this, but it's basically helping reset the heart in a way. But we also need to consider one other protein channel here. This is called a sodium calcium antiport. Sodium calcium, it's going to be an antiport, okay? Now think about this. Anti means opposite direction, right? So we're going to transport these in opposing directions. Now normally what will happen is sodium will actually flow outward in this, and calcium will flow inward in this. Okay, so sodium is flowing out, calcium is flowing in. Okay, why is that important? Well, it's equal and opposite. So anytime we lose sodium, we're going to gain calcium. Lose sodium, gain calcium. Lose sodium, gain calcium. What's the goal here? What's the goal here with digoxin? Gain calcium, right? We want to gain more calcium. So in other words, we need more sodium here. If we have more sodium here, it's going to push that gradient so fast outward that it's going to basically suck in that calcium inward, right? So think that sodium is fueling this process. The more sodium we have inside the cell, the more calcium we're going to get, okay? I'm going to write that here. The more sodium inside, the more calcium is sucked in. Okay. Now, how do we keep more sodium inside then? Well, let's think about it. What is kicking sodium out? This sodium-potassium pump, right? So if we were to block this sodium-potassium pump, which digoxin does, let's see what happens. We block this process. So we put this big lock on it called digoxin. Well, now sodium cannot get out. Therefore, where does sodium remain? Sodium remains inside the heart. If sodium remains inside the heart, more sodium will then leave through these antiports, therefore sucking in more calcium, therefore increasing contractility, right? Through the same mechanism we talked about earlier with the sarcomere, right? So that's how digoxin works on the heart muscle to help it have more calcium for a more efficient, strong contraction. Now the same thing will actually occur in the SA node of the heart, okay? Basically telling the atria to contract and the whole heart to basically beat properly. So if this digoxin acts on the SA node, it's also going to keep sodium inside for a little longer, and it basically just helps reset that heart rate, keeping it pumping at a good, healthy clip rather than kind of shaking around a little bit. And sometimes you have to get what's called a cardioversion in order to kind of reset the electrical activity of the heart, but digoxin can kind of treat AFib in select cases. So that was a lot about the heart and the kidneys. So let's get a little more into the blood vessels, and then we're going to talk about some diabetes as well. All right, so now we're going to talk about some circulation diseases that we can fix with drugs, as well as diabetes. So let's start first with circulation. So with warfarin and heparin, two very common medications, both of these are considered anticoagulants. If we write out that word anticoagulant, we know that coagulant means to clot. So it's a blood clot, and we're going to oppose that. Now, why would we want to oppose blood clots? Because don't blood clots stop bleeding in a lot of cases? Absolutely. But sometimes if we do clot the blood, for example, that clot can actually dislocate itself from the blood vessel and then travel all the way through the bloodstream and then eventually plug it up somewhere else. So let's say if this blood went off to the side, you don't have to draw this and kind of narrow it out. That clot could potentially block that blood vessel and then cause basically an ischemic attack of some sort where we don't have blood flow to a specific tissue. Could be the brain and cause a stroke. It could be a deep vein thrombosis in the leg and turn into a pulmonary embolism where we've got this in the pulmonary artery. So there's a lot of bad things that can happen if that clot leaves. So in order to figure out how these two medications prevent that from happening, we first need to figure out how clotting happens in the first place, because then we'll figure out how these medications interact with it. So let's get started with this. We're going to start in the liver. The liver is kind of the common thread in a lot of these cases with medications, because medications usually deal with liver function. So we're going to zoom inside of the liver and look at a hepatocyte, literally translating to a liver, hepat, and then cyte, cell. Inside of the hepatocyte, we've got the nucleus in the endoplasmic reticulum, where we're going to basically generate proteins specifically called clotting factors. Now, in this whole diagram, whenever I draw red in this case, I'm going to think of this as inactive, okay? So these are all going to be inactive clotting factors, inactive clotting factors. Now, I've designated them with Roman numerals based on the number. So like this is clotting factor 2, or the inactive form of prothrombin, and then 7, 9, and 10. Now, normally functioning, the liver is going to be making these inactive clotting factors. They're going to be circulating throughout the bloodstream pretty constantly, but they're not doing anything unless there is damage, okay? So in the case of damage, right, we need to turn them from inactive to the green form, which green means go, to active. So I'll look at these green ones. These are active clotting factors. Well, the question is, how do we take inactive forms of clotting factors and turn them into active? Well, for these 4 types, we need a molecule called vitamin K, interestingly enough. So vitamin K we get from our diet. I'm just going to write K, vitamin K, VK, we'll do that. And we eat vitamin K through spinach, through nuts, supplementation, and we get it into our bloodstream. The liver will actually take up that vitamin K and bring it inside of itself. Now, vitamin K by itself cannot do anything, really. It actually has to be converted into a form called reduced vitamin K. So I'm going to draw this vitamin K turning into reduced vitamin K. I'll write it here, RVK, reduced vitamin K. Okay, so we're just altering the molecule ever so slightly. And the way we do this is through an enzyme called, as you could probably guess, reduce. It's called a reductase enzyme, reductase enzyme. We know it's going to reduct, and then it's an enzyme ACE. Now, from there, this reduced vitamin K is the key here, because it will interact with these 4 clotting factors, and with RVK, and with these 4 inactive clotting factors, we will then form the active form of the clotting factors. So I'm just going to write activated clotting factors. Very good. And that is why vitamin K as a dietary supplement is very important in order to clot your blood. Makes sense. And in fact, when my firstborn son was born about 4 months ago, we actually had him get an injection of vitamin K, so that in all those vessels that are needing to close up, that vitamin K helps him essentially clot the blood where it needs to be clotted. Because obviously when you're born, there's a lot of stuff going on. You need to stop that bleeding. Okay, so the activated clotting factors obviously will leave the hepatocyte and get into the bloodstream. Now, I want to point out here that at this point, why did we do that? Why did we activate them? Because the liver had received signals about damage. So I'm going to say that all of this only happens when the liver detects that damage. So when the liver detects some sort of vessel damage through a variety of different molecules and inflammatory markers, that's when this is really going to ramp up. We're going to make the activated clotting factors. They're going to get into the bloodstream. Okay, We're going to come back to vitamin K here in a second, but we're going to go and talk about what these factors do, obviously, to clot the blood. So we've got damage here in the blood vessels. We've got activated clotting factors. They can't do anything really by themselves. In order to make something happen, we actually have to activate this second clotting factor into something called thrombin. Now this is thrombin, and that literally translates to basically the clotting protein, okay? And thrombin is going to become activated when all of these clotting factors are present. So thrombin is activated with the active clotting factors present, okay? So since they're present, boom, we're going to activate thrombin. Well, what do you see thrombin able to interact with? Well, we see a little indentation here, kind of looks like a circle, where it can interact with this protein over here. And this is always circulating throughout the body as well as coming from the liver. And this is called fibrinogen. Fibrinogen. We remember from the past thing that fibrinogen literally translates to inactive form of something. Inactive form of what? Fibrin. So this isn't doing anything. However, once thrombin is activated, this clotting protein, fibrinogen is going to bind to it and be transformed into something called fibrin. Now, fibrin is incredibly important because as platelets accumulate in this location of damage, so I'm basically superimposing this damage right here, platelets will begin to accumulate here, right? Because platelets are those clotting cells, okay? And we need to secure them to that clot so it can't travel. So what fibrin is these long threads of proteins, it's literally called a fibrin net, that will come and accumulate around the platelets and essentially, just like netting fish, will secure that clot to that vessel. Okay, so it's basically just like taping that clot down so it can stay there and then not break off and go all over the other places, right? So that's how we clot the blood, through a variety of different factors. Now, these factors are involved in both the extrinsic and intrinsic pathways, intrinsic being internal damage to the vessels, extrinsic being damage from the outside, basically like you get hit and you start bleeding, right? So all of this occurs and now we are securing that clot. However, what did we say? What did we say? We want to prevent this from happening. So enter in our anticoagulants. The anticoagulants are going to act on a certain part of this pathway in order to stop it. So let's start first with warfarin, okay? Now, warfarin is going to target specifically this vitamin K pathway, okay? I always remember that warfarin, W kind of looks like V for vitamin K, okay? So it's going to affect vitamin K. How? Well, let's come back here. And we saw that reduced vitamin K activated those clotting factors, right, to allow for the clot to form. But that reduced vitamin K is going to go through a cycle where it will actually get oxidized and turn into oxidized vitamin K. So I'm going to write OVK. And then that oxidized vitamin K needs to get further transformed back into the original vitamin K, the dietary form of vitamin K. This chemical reaction is done by an enzyme called an epoxide reductase. Epoxide reductase enzyme. You see a common name here, reductase, right? Well, the reductases are going to be the target of our warfarin. In fact, warfarin, I'm just going to write as a big W, okay, so big W, is going to come in and inhibit epoxide reductase. So I'm going to draw it like this. So warfarin comes in, blocks epoxide reductase, and it also just blocks this generalized reductase as well. So what can you predict to happen? Well, if we can't reconvert oxidized vitamin K into vitamin K, nor can we convert vitamin K into reduced vitamin K, what's going to happen? Well, this will decrease the amount of clotting factors. So we can basically say warfarin decreases the activated clotting factors, therefore they stay inactive, therefore we cannot clot the blood. That's how warfarin works. Now, let me say this. This does take a few days to take effect. So warfarin usually takes about 3 days to take effect because we're going to slowly deplete these forms of vitamin K, preventing the clotting factors, because there will be some active in the bloodstream in the liver that will have to slowly diminish over time. Now, the problem with this is usually people have to take vitamin K supplements because we're going to drastically reduce the amount of vitamin K, which is also important in other biological processes. Wonderful. So that is Warfarin. Great. Good job, Warfarin, for declaring war on vitamin K precursors and conversions. Great. Now, how does heparin work? Well, heparin is going to be like a matchmaker, okay? It's going to bring two things that are so far apart together to make something happen. Okay, kind of like Hinge or whatever dating website you go on. So heparin's gonna swipe right or whatever direction you swipe. How do we do that? Well, I didn't mention this protein down here that the liver is also going to produce. This is called antithrombin 3. Antithrombin 3. Now, this is commonly produced by the hepatocytes. Once again, it's going to be dumped into the bloodstream here and there. But the problem with this is it doesn't really find its target very successfully. So we'll have AT3, I'm shortening it up here, in the bloodstream. And what does AT3 likely do? Well, look at the name, antithrombin, right? Look at the shape, look at thrombin. AT3 and thrombin can bind together, okay? They can bind together, and actually what happens is if I draw that, so here's thrombin coming in, I kind of drew it all weird looking, right? So here's our thrombin molecule. Let me redraw it. And when thrombin and antithrombin 3 interact, I drew this in orange. This is going to inhibit thrombin. So it's going to inhibit thrombin, okay? Which obviously, if we can't make thrombin work, we don't make fibrin, we don't make that clot, okay? So this is going to essentially inhibit the production of fibrin for that clot to produce. Now, the problem once again is what I said, is we struggle to find thrombin, okay? So it is difficult to find. I'm just gonna say difficult to find, just like it's difficult to find a perfect person in this world for you. I'm very lucky that God led me to my wife. It's been a fantastic journey, about 5 years of marriage now. Let's go. It's been a blessing. So we need help to help antithrombin 3 find thrombin so we can prevent coagulation. How do we do that? Heparin. Heparin is going to come in here and look like this. This is going to be the weirdest shaped molecule we have today. Okay, heparin, again, is going to play matchmaker, helping these two guys find each other. How is he shaped? Well, he's shaped something like this. Look at this. This is going to be our molecule of heparin. Heparin binds both of them. It basically grabs AT3, grabs thrombin, and provides that connection to then inhibit, right? So inhibiting thrombin through heparin. So heparin, once again, helps AT3 and thrombin interact. And that obviously leads to no coagulation. Specifically, no fibrin being activated. It'll actually stay in that original form of fibrinogen. So that is how these two very, very common drugs target the cells, specifically in the hepatocyte, as well as some other factors, so that we can prevent coagulation, prevent strokes and thromboses, and all sorts of wonderful things that are bad. Okay, so now let's move on into diabetes. Okay, diabetes, we're going to talk about two different types. Type 1, where is when we can't produce insulin, so we're going to treat this person with insulin, a hormone. And then we're going to talk about metformin, very common a drug for type 2 diabetes, okay, where it's characterized by high blood sugar, chronic high blood sugar, usually due to dietary and lifestyle issues. So let's start first with insulin. Let's talk about the mechanism of insulin. What's going on here? Well, we know that insulin is going to reduce blood sugar. So in your blood, I'm going to have a type 1 diabetic here, and they have a lot of glucose. So this is going to be our glucose, base unit of monosaccharide. It's a sugar, and we have very high glucose level. It's called hyperglycemia due to type 1 diabetes. Why? Because insulin, normally functioning, is going to lower blood sugar. It's going to decrease glucose in the blood. Well, how does it do that? Simply put, insulin acts as the key that unlocks the doors to cells to take the glucose from the blood into the cell, specifically the liver and the muscle. So again, insulin is like a key opening the door for glucose to leave the blood so that then we can bring it into the cells, therefore decreasing our blood sugar. But how does that work? Well, let's look inside that liver cell, okay? So inside this liver cell, here's our liver cell. We're going to talk about insulin first. We've got a receptor class here. This is called an insulin receptor. So I'll write insulin receptor right here. It's sometimes shortened up IR, but I know that as injury reserve in the NFL, where a lot of my Indianapolis Colts players usually end up on. So like and subscribe for the Colts, who will probably lose a lot again this year. Anyway, moving on. So insulin receptor, IR for short, is going to obviously be a membrane protein embedded in the membrane that's going to bind to that insulin whenever it is present. So let's say we're treating this person, type 1 diabetic, and they can't produce insulin, so we just gave it to them. Okay, what happens next? Well, we know when insulin right here binds to that receptor, we're going to activate a cascade, a G protein coupled receptor, and that is going to activate a protein called PI3K. Phosphoinositide 3 kinase. Big long word. I want you to focus on the K here, kinase. Anytime you're activating a kinase, it's an enzyme, and kine usually means movement or kinetic energy, right? This is a protein enzyme that is going to activate, basically get into motion, all sorts of other things. One such thing is going to be something called intracellular trafficking. Intracellular trafficking. It's exactly what you think it is. What is traffic? Movement of cars and stuff, right? Where? Inside the cell. So we're going to be moving things inside the cell because this kinase is kind of kicking them into action. So what are we going to traffic? What are we going to move? We are going to move these vesicles that are pre-made. So vesicles are basically cell membranes here that can embed into the membrane. And embedded inside of them are things called GLUT4, not your glutes as in your muscles, but glucose transport proteins that are embedded in the membrane. So again, these are glucose transport proteins, okay? So we're going to move these guys out from that protein kinase to the membrane. And we're going to embed those protein transporters in the membrane here. Well, as you can guess, now that we have the transport proteins, glucose has somewhere to go. It will come into the cells, which is absolutely fascinating. This is actually what happens in the muscle cells, liver cells, in the hepatocytes. Now, quick question for you who are taking A&P. Why couldn't the glucose get into the cell in the first place? Why do we have to have these transporters? Well, it's because we know glucose is hydrophilic. Okay, it's a polar molecule, whereas the lipid membrane is hydrophobic. It's a lipid molecule, and they don't mix. So generally speaking, hydrophilic things, dissolved things in the fluid of the blood, cannot pass through the membrane unless they have a protein channel. Great. So we're bringing glucose in. That's great because what's going to happen? Well, blood sugar is going to decrease, which was the goal, right? Type 1 diabetics usually have high blood sugar. We got to take insulin and we got to pull that blood sugar down, and we're doing that. Wonderful. So that's how insulin can treat type 1 diabetes. That's the mechanism of which we do that. But here's what I want to get into. This leads to energy production. How? We know, and this is going to relate to metformin, so stay with me. We know that this glucose, right, is kind of a base carbohydrate unit for energy. There's a lot of energy packed into glucose. And glucose will come down here, okay, to the mitochondria, and it'll go through a process called glycolysis, where it's actually going to turn into something called pyruvate. Pyruvate's basically just a 3-carbon chain molecule, and then that pyruvate will go into the inner mitochondrial membrane and go through something called the TCA cycle, citric acid cycle. You may hear a lot of Krebs cycle, you hear a lot of other things. And from that, we're going to produce a lot of high energy intermediates, eventually leading to something called the electron transport chain. If you want to learn about these, you can watch them in these videos here. But I'm just going to summarize the electron transport chain. When we have plenty of oxygen, so we're breathing plenty, oxygen's getting into these cells, we can produce a massive amount of ATP from this process, okay? Usually 30 to 34 ATP per round of electron transport chain. Why is that important? Why is that important? Well, we know, I'm going to draw this actually in red. We know that ATP is the energy currency molecule for cells, okay? So if this liver cell has a lot of ATP, what does that mean? Well, that means it's got plenty of glucose coming in it, right? Plenty of glucose, plenty of ATP. So we are actually in what we call a high energy state inside of the hepatocyte, the liver cell, okay? So that means we have high ATP, high energy state. So what we're going to do is we're going to prioritize storing, okay? And we're going to have very little glucose uptake. What does that mean? Well, when we have plenty of ATP, it means we have plenty of glucose. Once we have plenty of glucose, do we need more? No, the liver's like, whoa, 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 we've already gotten our sugar for the day. We don't need any more. So what's going to happen, I'm not going to go through the details of this, is this high ATP is actually going to inhibit this process of intracellular trafficking. Okay, follow me here, follow me. If we prevent this process, what will we prevent? There's another blooper. We will prevent this from happening, right? We won't push out glucose transporters. And if glucose transporters are not getting pushed out, guess what? We're not going to have any possibility for glucose to come in, correct? What does that mean for somebody, switch your brain, who has type 2 diabetes? Type 2 diabetes. Well, type 2 diabetes is when you have, I'm going to underline type 2 diabetes, is when you have chronic high blood glucose, but it's due to something called insulin resistance. Insulin resistance. What does that mean? The liver is packed full of ATP. It's going to prevent this process from happening. What kick-started this process? Insulin binding, right? So now, even though these type 2 diabetics make insulin just fine, the insulin's binding, this process is going, but since the liver is in such a high energy state, it's going to block the process of getting the glucose into the cell. That's a problem because if glucose can't get into the cell, where is it going to remain? Well, it's going to remain inside of the blood. And if it remains inside the blood, it can actually lead to a process called diabetic ketoacidosis, where instead of using glucose for energy, we're going to switch, use some fats, and then we're dumping a bunch of ketones in the blood, and it makes your blood super acidic, okay? Not going to go into the details of that, but that can cause some issues. So we need to figure out a way, think about this, we need to figure out a way to trick the liver cell into continuing to bring glucose out of the blood into itself. We're going to trick it. How do we do that? Well, we're going to trick it into thinking it is actually having a very low energy state when we have low ATP. Okay? So, think of the end goal. We need to trick the liver cell into thinking it actually has low amounts of ATP so we can prioritize, again, bringing in glucose. Why? Because if we don't have ATP, it means we don't have enough glucose, correct? So how are we going to do this? Well, come in, metformin. Metformin. This is a very common type 2 diabetic drug, and I'm going to draw it as a triangle. When we take this drug, when a patient takes this drug, I don't take it, it's going to come into the bloodstream. Okay, here's metformin. Metformin is going to pass through these organic cation transporters, OCT, generally OCT1, sometimes you see OCT2. And they're found in the liver, also found in the muscle cells. We'll just talk about the liver. So metformin comes in here, all right? And if you look, metformin is going to come in. Let me label it quick just so you don't get lost. Metformin is going to come in, and do you see any sort of receptor that would bind a triangle inside of the liver cell? Well, if you look carefully, you see it's actually in the electron transport chain here of 4 proteins, specifically in complex 1 of the electron transport chain that produces ATP, right? So metformin comes on down here and attaches inside, well, onto complex 1. When metformin binds to complex 1, it will inhibit it. So I'm going to write metformin will inhibit complex 1. It's going to basically prevent it from working. Well, what does that mean? If we break the chain of events that starts here and goes to here to make ATP, what are we also going to inhibit then? Well, we're going to inhibit ATP synthesis, right? We're not going to make as much ATP. So that leads to metformin, by binding to complex 1, it's going to lead to what type of ATP amount? low ATP amount inside of the cell. Now, this is where it gets kind of interesting because the liver now thinks it has low energy. So we have a marker for that inside of all of our cells, really, and that's called AMP, adenosine monophosphate. It's basically an ATP with just one phosphate, and that is going to be high. Don't ask why, it just is. It's usually inversely proportionate to ATP. So when ATP is high, AMP is low, and vice versa. So when ATP is low, AMP is high, and this is going to signal, again, a low energy state. Low energy state. So, since we're in a low energy state, think about it. What would we want to hypothetically do to help get the energy back up? Well, we would need more glucose to make more ATP, hypothetically, right? So here's what's going to happen. AMP is going to go and activate AMPK. Can you predict what K likely means? Kinase, right? This is AMP kinase, and we know once again that kinases like to move things, like to do intracellular trafficking. So what's really fascinating is AMP kinase will begin going and helping to stimulate the pushing out of these vesicles once again with those GLUT4 proteins. So now what do we have? Well, we have those proteins now allowing glucose into the cell. What will that do? Obviously, that will help to lower blood sugar, right? Because if glucose is coming in, it's getting lower inside of the blood. Absolutely fascinating, right? So by tricking the cell into thinking it's in a low energy state, we now trigger this process to get glucose into the cell, basically a different route than normally, right? Now this is where metformin is something called it's a molecule that helps insulin sensitization. So I want you to remember that metformin right here increases insulin sensitivity. Why? Well, because if we're triggering this process that triggers, again, this intracellular trafficking, I don't want to make this all ugly, but this could trigger intracellular trafficking, thus bringing those membrane with the proteins inside the membrane, boom, that's amplifying what insulin was already doing, right? So again, AMP kinase moves those out, brings glucose in, and it's also going to do a couple other things you may see in the textbook. That AMP kinase can also diminish gluconeogenesis. Break down that word, glucose new creation, okay? Glucose new creation, it's basically diminishing the amount of glucose the liver is putting out, right? Because the liver a lot of the times can push glucose out into the blood when we need it, but since we're inhibiting that process, there will be, again, less glucose getting into the blood. Less glucose getting into blood from the liver. All in all, y'all, lots of rhyming. All in all, these processes will diminish the amount of blood glucose in the blood, obviously, so that we can treat type 2 diabetes, which is characterized by chronic high blood sugar levels. Well done. Hopefully this was very energetic and engaging. And now we need to talk a little bit about some relatively easy compared to these guys, asthma. So we need to open up those bronchial tubes in the lungs, and then pain and fever. We'll talk about acetaminophen and some NSAIDs and that type of thing. All right, so if you've made it to the end of this video, it's likely that you popped one of these pills before you're finishing out here because you needed some pain relief after all of this learning. So in this video, we're gonna talk real quickly about pain relief medications, fever-reducing medications, as well as how we treat asthma. So let's start first with these three. Acetaminophen, generally known as an antipyretic fever reducer. And then we've got NSAIDs, non-steroidal anti-inflammatory drugs. We're going to diminish inflammation with ibuprofen and aspirin, and or corticosteroids like prednisone, cortisone, a little stronger ones. We don't usually use these unless they are prescribed, whereas these two are over the counter, these three. So let's talk about what's happening here in terms of inflammation, pain, what have you. Well, whenever we're talking about pain and inflammation, we got to talk about prostaglandins, okay? These are these basically factors, proteins that are produced during an inflammatory reaction. Now, why do we do this? Well, prostaglandins do several different things. Number one, it includes vascular permeability. So we're going to have more vascular permeability when we make these. What does that mean? Well, that means we can move in and out of the what? Vascular, the blood vessels, so that white blood cells can move properly, right? So white blood cells are going to attack all of those foreign things. So let's say if you have an infection, we need those white blood cells to be able to get to where they need to go through the blood vessels. So therefore, prostaglandins help with that. Not only do they help with that, but they also help navigate those white blood cells, These are going to act as things called cytokines, and there's other proteins that are cytokines. Cytokine literally means to move cells, okay? Cell movers. So it's going to draw the white blood cells to that location of inflammation or infection, which is going to be really, really helpful. Now, it's also going to produce a fever. Now, generally speaking, fevers are caused by the pyrogenic prostaglandins. So pyrogen means heat creation. And that is because they act on the hypothalamus. And the hypothalamus, we know, is the main regulator of what? H homeostasis. And that leads to an increase of body temperature whenever these are produced. So it makes sense that if we diminish these suckers, we're going to help lower that fever, lower that body temperature, okay? But these are good things that need to happen when we have an inflammatory reaction or an infection, okay? Obviously, the downside to these is it does produce pain, okay? Now, why does it do that? Well, prostaglandins are known to sensitize different sensory neurons, basically making them more sensitive. So therefore, if sensory neurons are detecting any one sort of painful stimulus, they're going to send that signal every time. And in fact, when they sensitize it, it increases the amount of a neurotransmitter called substance P. I always think of substance P as the pain neurotransmitter, okay? So all in all, if we produce these prostaglandins, we're going to draw white blood cells to the area, we're going to help inflammation, we're going to make a fever, but we're also going to have some pain and general feelings of malaise. So how do we fix that? How do we diminish pain? How do we diminish fever? Well, let's check them out. Acetaminophen and NSAIDs and corticosteroids are all going to affect a process of how we produce those prostaglandins. So let's start with the beginning and then move our way to prostaglandins to figure out how they work. Well, first off, phospholipids are kind of the first start to it. What are phospholipids? Well, we know that phospholipids, whenever we have an excess amount of them, this means that cell membranes, which are made of phospholipids, so if you look at any sort of cell, whenever I've drawn a cell in this diagram, these are phospholipids, right? Making up the cell membrane. And this is basically cell membrane remnants, okay? So basically we burst open some cells and there's just phospholipids floating around. Well, that indicates usually some sort of an infection with either a virus or a bacteria, because they also have phospholipids. So therefore, if we damage them, if we fight them off, there's going to be some of the cell membrane remnants. Whereas remnants, I spelled that wrong, remnants. As well as if white blood cells are fighting the battle, sometimes they die off in the first place too. So we could have white blood cells dying, leaving their cell membranes around, and we have a lot of phospholipids out here. Well, obviously cells are going to notice this, white blood cells, other cells like kidney, stomach, and they're going to notice that, and they're going to use an enzyme called phospholipase A. That's going to transform the phospholipids into an arachidonic acid. Now, why are we doing this? Because lipids don't move throughout the bloodstream very well, and it actually can cause some clots and bad stuff. So we're going to turn it into arachidonic acid. We know that acids dissolve well, okay? So it's kind of a way to dissolve the stuff that's left over, okay? So what do we do next? Well, arachidonic acid will be converted directly into prostaglandins, basically in an attempt to fight off whatever's going on here. That is done by several different enzymes. We're going to focus mainly on the COX family of enzymes, COX-1 and COX-2. These stand for cyclooxygenase enzymes, okay, and they're going to convert this to that. So where do our medications come in? Well, first off, phospholipase A can actually be inhibited by our corticosteroids. So therefore, we're basically blocking the very beginning of this whole process, not even allowing these phospholipids to get converted, therefore diminishing our inflammation, diminishing the amount of prostaglandins we have. Whereas the NSAIDs as well as our acetaminophen, if I can spell and talk at the same time, will both inhibit COX enzymes, okay? If we do that, obviously less prostaglandins. Now, acetaminophen, I have to mention this, usually works best on central nervous system enzymes, so the COX-1 and 2 enzymes in the central nervous system, the spinal cord, and the brain. So it is usually better at fever reducing because we know what's inside of the central nervous system? The hypothalamus. It's a part of the brain. So usually acetaminophen is a little better at fever reducing compared to the NSAIDs. Now that being said, aspirin and ibuprofen can lower fever. It's just less effective, generally speaking, than acetaminophen. And certain people respond differently to it, okay? So therefore, we call any fever reducing medications antipyretics. Antipyretics, basically anti-heat, okay? Brilliant. That is all I have for the pain relief medications. Let's talk about albuterol and Epipens if we're really dire. So we've got inside of the lungs, we've got the trachea here, and then they will branch off into two main bronchi, okay? Literally translating to branch. And then those are going to branch off into smaller bronchioles. Now we know at the very terminal ends of the bronchioles, we have those alveoli, basically air sacs, that are going to butt up to our bloodstream and allow the exchange of gases like carbon dioxide and oxygen. Incredibly important. We'll bring in that oxygen into the bloodstream, we'll take that CO2, put it out into the air, right? So the question is, what happens with asthma, right? Well, asthma is designated as bronchospasms, where basically we are taking the bronchi, right, a cross section here, and we're closing them up. Why does that occur? Well, with asthma, it's usually due to some sort of allergy, okay, maybe like seasonal allergies, or maybe it's as deadly as like a peanut allergy where it completely closes them up, or it could just be like exercise-induced. Some people have exercise-induced bronchospasms or exercise-induced asthma, where, once again, it stimulates those smooth muscles, closes them up, and it's called bronchoconstriction. Bronchoconstriction, where those smooth muscles again get stimulated to close up. So you kind of see them doing that here. So if we close those up, now we have a very narrow passageway for air to travel into the alveoli. Therefore, we can't breathe very well, and that is not good. It's almost like sucking out of a straw trying to breathe. Very bad. So how can we help this? Well, we know albuterol and Epipens are both considered something called beta-2 agonists. Beta-2 agonists. Okay, albuterol is a little lighter one, and Epipens are really, really strong. Well, what are beta-2 agonists? Well, we know beta-2 are these receptors here. So these are beta-2 receptors on the smooth muscle inside of the bronchioles. Isn't that kind of interesting? You have smooth muscle wrapped around there. It's just still weird to me, right? And they've got these receptors. Well, when albuterol, I'll draw it as a square, binds to these receptors here, what will it do? Well, that will stimulate bronchodilation. So I'm going to write bronchodilation when albuterol or epinephrine, Epipens, another name for epinephrine, binds to these. Alrighty? So we call these bronchodilators, opens up the bronchioles by relaxing the smooth muscle, and therefore you can breathe again. So as long as those guys are bound there, we're going to keep those airways open. Now, how do we administer, obviously, albuterol? Well, that's generally directly by breathing it in. It's an inhaler, right? Comes on in here, begins binding. Whereas epinephrine, interestingly, we administer it intramuscularly. Now, this is kind of interesting. You're jabbing epinephrine into a muscle. How does it get to the lungs then? Well, we know that blood goes everywhere, and when you jab it into the muscle, very blood-filled organ, that's going to travel eventually back to the heart, and that's going to go to the lungs very, very rapidly, therefore binding, therefore opening up those airways. So it can save somebody's life if they are in what's called anaphylaxis, where that allergy closes those suckers up, then they can't breathe. So, hey, we are at the end of all these drugs. Hopefully this was helpful and interesting. If you want to learn more about the diseases, I recommend watching this video next. But if you're interested in just pathophysiology or anatomy physiology, check out these videos to the side. Thanks for watching.